The ones that you and I do most of the time is a go for the money exam. So we see a 70-year-old athlete comes in with shoulder weakness, so we assess his strength, and it's weak, and we say you got a rotator cuff tear. So that's our directed exam. So we do that a lot. Run onto the football field, players down, we do a Lockman, he's got an ACL tear. So that's go for the money, so we keep that in mind. However, we need to be able to go from A to Z and be comprehensive. And Keith laid that out nicely, but inspection, palpation, range of motion. If we're going to do range of motion, we probably should assess strength in there. If we're going to assess strength as part of a neurological, so we better think about neurological somewhere. Stability testing, and then sort of special tests. And the reason we have special tests, we may have missed doing a speech test or some such test or apprehension sign in the shoulder and what have you. So if we inspect for something, so we go through that sequence. Lower extremity, we stand and walk and do a gait analysis. Upper extremity, maybe not so pertinent to do that. So if we're going to start, we have to have an organized format, as you're all aware, and you all have your routines. But we sort of look from the back, the front, the side. We go superficial, deep. We go soft tissue, bone. So we have a division of all these things that we keep in mind as we go through the examination. So we look for the same things at every part. So it's fairly obvious. I get Baker to stand down here and turn toward the wall. Not that we don't want you seeing, but if we look, then we look for, what would we look for? Keith mentioned about, but always we look at muscles, big, small, wasted. We look for deformity, scars, clavicle stepping up, scar in the shoulder, something like that. We look for redness, color. We look for swelling, not so much in the shoulder, but we certainly do in the knee. So those are things we look for. Alignment in the lower extremity, not so much in the upper extremity. So if we look for muscles, so just in no critical order, but for me, I would look at the infraspinatus. If he's got infraspinatus wasting, a young guy like that, he's got a suprascapular nerve knockout probably. If he's an older person like myself, he's probably got a rotator cuff tear. Then we look at the deltoids. So the infraspinatus is easy to see in the scapula. It's superficial. Supra is the main muscle, but we can't see it. It's covered by trapezius deltoid. While he's here, we look at the scapula, and we'll come back to that because we won't forget to examine him for the scapula. So we turn him around forward. We look at his deltoid. And sometimes we ask somebody to do something about their muscle so it looks pretty full, not wasted. So we'd ask him to flex his biceps, show us. Older people might tear their biceps, and it would be down here instead of up there. We say, you got a biceps tear, must have a rotator cuff tear too. So we often ask people to do certain things to bring out muscles. If we want to look at his pectoralis, I won't stand in front of him, but we'd hold him here and ask him to pull in, and so we can see and palpate his pec. And so those are things that we look for. He doesn't have any swelling, it's not red, he has no scars, his clavicle's not sticking up in the air, he has no deformities. So we look at those things, inspection in all people. So next we go to palpation, if I may suggest. So what do we palpate for? Well, we palpate known areas of anatomy where we know there's pathology and we can elicit some, usually tenderness. But we might elicit crepitus as we're palpating. We might feel fluctuance or swelling. So if we're going to start at the shoulder, we could start somewhere. We might start at the neck and go out. We're going to look at we palpate the front, top, back, side. So same thing by looking. We look from all these areas. We also palpate from these areas. So if we start here and go along his trapezius, we can back out, we can palpate along his clavicle. Not much to see there unless it's got no non-union. If we fall into the visor's portal, which is right there where the clavicle turns sideways a little bit, please. Clavicle goes here, spine here. So that's the visor's portal. Now if we turn back this way a little, we know that right in front of the visor's portal, right there is the AC joint. You can see it in Bake. So right there is his AC joint. We palpate it for tenderness. And if we slide anterior to the acromion, put his arm back, that brings us to Codman's point. The greater tuberosity is right there. Now, why would I palpate greater tuberosity? Because that's where they have a cuff tear. It's where it all starts. Then we put them in the mid, slide down to feel biceps tendon for tenderness. Roughly, can't feel the biceps tendon, but we can roughly feel the area. And as we're doing that, we feel for any crepitus or any other qualitative aspects of our palpation. So we really are looking for palpating for tenderness. If we turn Bake around, then he may have trigger points back in here. You all know about the therapy people and trainers know about levator scapula. It's often tender when patients have a shoulder problem or a neck problem. Well, we're up here. When are we going to do his neck? We're responsible for his neck and his elbow, joint above, joint below, so maybe we'll do it now since we're here. So I would just palpate posterior cervical spine for pressure. I'd rotate him while we're here, stress him at the extremes, looking for pain, and so he doesn't have any pain. Then we'd rotate him, laterally flex, and compress, so that's Sperling's. And if they're all negative, I say his neck's normal. So I hope we're right. We're usually right. But you still could have a silent disc in there. So that's sort of what we do for our palpation. Now next we go to range of motions, and you and I have to agree upon what ranges we're going to document officially on a piece of paper. So if we look at his ranges, we usually do 4. Forward elevation, external rotation arm to the side, internal rotation as to where the hitchhiking thumb or index finger reaches relative to the posterior spinal anatomy, and then external rotation in the abductor position. Now we do a couple others as athletic people because we want to look at throwers, so we want to know how far they go back, we want to know how much internal rotation they have. So with Baker we turn them just to the side, and so I stand behind and guide, so I ask him to elevate your arms as high as you can. That's the frontal plane. So he's got full, and this is age related. If he's, see, I don't go as high as he does because I'm older. But he has full elevation, and that's not in the sagittal plane, it's not in the coronal plane, it's not in the scapular plane, it's sort of in the frontal plane, somewhere up between sagittal and scapular, so about here. And we measure that measurement with the thorax. He's really good, isn't he? So he's 170 degrees. You think he's 180. He's not really 100 because he's just right there. So we always push when we do that, active, passive. Why do we push? To elicit pain. First reliable sign we get with a diseased part is it hurts when we stress them at the end of the range of motion. So we do that. Now since we've done that, should we measure strength there? I guess we measure forward elevation strength. So then we do, again, guiding him, standing near him, active external rotation, arms at the side. So if you do it here, he's got that much. If you let him do it out here, he's got 20 degrees more. So where do you do it? Well, you know, fairly comfortable at the side. I put a finger in there and then just sort of hold him in and out an external rotation. And we're supposed to document 0 to 60 degrees. Or if one's abnormal, we say he lacks 20 degrees on the involved side. So since we're here, I guess we might as well assess his strength. Remember, range of motion strength. So we ask him to push, or we could put him in here and do it, or we could put him, where would we put him? I would put him here, because that gives him a biomechanical advantage. So I'd put him there, and I'd say, hold out, and I'll push in. So, see, he thinks he can beat me. Now, while he's there, we might as well assess internal rotation. I'll take him on this one now. Okay, you pull in now, so. I just broke my tooth. No. So anyway, internal rotation is subscapular, so we'll circle back on that. So we do elevation, external. We measure strength of external, internal, since we've done that. And then we ask him to reach behind his back, up as high as you can go. And so T10 is in, he's got scapular winging. We're going to come back to that. T10, he's about T9. He goes from thumb to index. So it's sort of crude, isn't it? But it's the best we have. And then we compare. We're supposed to compare. Oh, he goes higher there. Wow. Good. So that would be about T3, the spine's T2. So we're supposed to know those things.
Try that again.
Oh, bad. So now, since he's there, and we don't want to forget, so that's internal. Now, we'll measure, we should do the supine, but we'll measure in abduction, external rotation. So he's pretty symmetric. He actually goes a little farther on the right, doesn't he? Maybe 10 degrees farther. Did you play baseball? No.
Not well.
And what about your scapula? It's all out of whack. So we're going to do that supine too, but we do it there. Now, we should measure external rotation strength up here. We who do total shoulders and look at reverse arthroplasty, because this is teres minor up here. And there's other tests we do. If we ask them to pull forward here, that's the biceps in the groove, and if they have biceps pain, this is what hurts them. So these are just non-specific tests. Believe me, we put all these tests together. Like if you got a meniscus tear, you got quad wasting and a fusion, medial joint tearness, painal extension, painal flexion, and a positive Mcgehee, you got a meniscus tear. So I mean, if you put them all together, clustering test, it helps you some on that. So that's what we do for ranges. Now, we're going to lay you down on your back, if you would, here. Either way, yeah. So if we want to more accurately do rotation in a thrower, which we often do, so we take his arm here and bring him back. And so that's 110 maybe. So now, how do we, Chuck, are you here? Chuck knows how to do this, but so in doing this in ball, we do all the Rockies at spring training. Chuck and Alan come out, we do that, and Mike was there this year. So we sort of feel coracoid, ball, and we bring them back until we feel that move, and then we stop. And it's a little subjective. It's even harder with internal rotation, which we do in throwers. So I'm feeling his coracoid and and then we take them in, and as soon as I feel it move up here, then we sort of stop and give them that measurement. And baseball players, as you know, they go farther on their involved side and less on their involved side and internal, but they have the same arc. So we'll just look here. Yeah, so he's 10 degrees more on this side, which means he's likely going to be a little different on that, the arc being the same on that. So that's how we do that. Now, since we've done this, then we might as well do a couple other tests while he's supine, not to get out of sync, but we don't want patients sitting, laying, standing. So up here we would do an apprehension sign. Dr. Mattson calls this a fulcrum test. So you can take him back here and look at his face and see if he's apprehensive. Now you can accentuate that by putting your hand back and pull. And so I'm looking to see if he's not apprehensive, so he doesn't have any instability. If he was apprehensive, he would have anterior instability. That's a really good sign for maybe the best sign we have in the shoulder. So that's a good one for that. Now there's another test that we do called a relocation test in a thrower. And a relocation test is for pain, for internal impingement that we have at the back of the shoulder. So we take him up here again. Now we put him back. And if we want to accentuate, we can put our hand in here. So we put him back. And now this hurts. Does that hurt? It hurts, you see? So that hurts. So that's, now what we're going to do is push up here, push back, and see if we get more external rotation and less pain. And that's what we achieved here. So he has a positive relocation test. Has nothing to do with apprehension. Now that's for pain. So that's an internal impingement or a slap manifestation in the shoulder. So that's a good test for that. Again, these tests are not perfect, but they are what we do all the time, try to put them together. So we'll get him to sit back up again. And so now we're still going through our deal here in terms of range of motion, strength testing. Now neurological, we would do whatever was necessary. So if it's a neck problem, then we do a lot of neurological in terms of strength, motor, sensory, reflex, and so on. But we don't need to probably go that in Baker's situation, but just to keep that in mind. So what do we do now then? We do other motions. We look at elevation and scapular pain, push up, and assess supraspinatus strength. We can do it thumbs up or thumbs down. Pretty strong, and so that's we might do that test too. So oftentimes too, since we're doing all these motion exercises, in order not to duplicate and double up and so on, we might as well do the tests that go along with them. So if we do an impingement sign, we take elbow extended below, put our hand in the scapula and push up here and see if it's painful. In truth, it's not really impinging there, but we call that an impingement sign to the shoulder. And so it comes down, that hurts. Then we inject them with some numbing medicine, do it again, takes the pain away. We call that a positive impingement test. Well, since we've done an impingement test, then there are other impingement tests. This one, some guys described it, forward flexion 90 and internally rotate. The tuberosity bangs against the coracoacromial ligament. That hurts. That's a positive impingement sign. And then while we're doing that, then we do a painful arc. Patients who have a painful arc with rotator cuff problems, when they lift their arm here, it doesn't hurt. When they lift here, it doesn't hurt. But when you take them posterior to the coronal plane here and they lift, it hurts right there. So that's a painful arc. And if it doesn't hurt, then we ask them to push up and break it down. And that often, because it's a working tendon that's irritated, it accentuates the pain and may bring it out when it's not there with just active motion. So we do then again assess the strength there. So whenever we assess strength then, as we're doing through this, and we're trying not to jump around. In my own mind, it's all organized, but not well. So when we do strength testing, though, our job is to say, okay, we give them the advantage. So for biceps, then I guess that would be about here. Okay, so we say, now you pull up. So I pull down. Now, if I can touch his biceps and palpate it, that's probably all I need to do, quite honestly. But we're supposed to do that, and then we're supposed to break it down if we can. And if you break it down, and then you compare it to the other side. So palpate it or visualize it, give them the biomechanical advantages, try to break it down if you can, compare it to the other side, and then we give it a grade. So 1, 2, 3, 4, 5, that's, 4 near normal, 5 normal. Well, that's not good enough because we need about 3 or 4 grades between near normal and normal, and we only have 1 grade in there. So a lot of people are 5 minus or 4 plus, and those are probably, that's taking liberties, but I think that's acceptable to do that. So we've gone through our various aspects, interior range of motion and so on. Now one thing we didn't do, if you'd be able to stand out for us, is we really didn't, face the wall please. We really didn't look at his scapula, although we did see it wing at one point a lot. So in throwers particularly, we do a scapular exam. So we ask them to lift both arms forward and we'll watch his scapula. So a scapula, see, sits, Chuck, are you there? Chuck's a scapula, world's authority. So scapula does a lot of things. You know, it does this and this and this and this and. So down you come back. So down slower now. Oh, up slower. Slow, slow, slow. So we're watching it. Comes out nicely. Down slowly. Slow, slow. We'll stop there. So now he's symmetrical, isn't he? So that's pretty down a little lower. Okay, pause there. So about this point, sometimes if we want to bring it out, we might put our arm across and ask them to push up. Okay, down a little lower now. So if they're going to scapular wing, it's about here that they wing. And we'll get Chuck to, when he comes up here, we'll get him to do his dance with the scapula because it's helpful to see how he does that. But we look at scapula and throwers particularly because all throwers have an abnormal scapula, almost. And people with instability, multidirectional posteriors, all have scapular wing. Someone who has posterior instability, they lift their arm, their scapular wings, wow. They lift their arm, their scapular wings, and their shoulder goes out the back, which is really weird. So then what we do is we hold the scapula down, and we ask them to lift their arm again, and now their shoulder can't come out because their scapula is maintained against the chest wall. It's a little bit of a paradox, but in fact, that's how it works. So we often, people who have scapular instability or scapular winging, we do a scapular stabilization test. So we hold it down. Do that winging for us again. He's really good. So that's voluntary, and then we would grade that by how much it is. So if he has a significant scapular problem, and we hold it down and he lifts his arm, and back down again, and it's really a terminal issue, then I fuse the scapula to the chest wall. I've done about 50 times, and that can be helpful, although it's only in salvage situations. So we look carefully at the scapula for those types of things. If you turn around again and sit on the edge of the table. So we've gone through inspection, palpation, range of motion, some strength testing we talked about, neurological we thought about, not much to do in Baker, and we looked at the scapula. So we're going along and sort of fulfilling most things. So we looked at impingement signs. So while we're doing that, maybe we should have done some other things like look for a slap tear. So a slap tear, O'Brien's test is flexion, what do you call that? What's that, Spiro? Resisted. So anyway, right here, 10 degrees in, hold the arm up. And any of these tests that we do provocative, we should try to break the opponent down. So hold up there, please. Now, so, okay. He's trying hard.
Hurts.
So it hurt. Did that hurt?
A little bit.
A little bit. So that's part one of a slap test. And so then O'Brien says, we have to ask him where it hurt. Where did it hurt?
Probably on top.
Yeah, so if it hurts on top, then we poke him in the AC. Remember, we've already done that. And then we do crossed arm adduction to see if that hurts. That's AC pain. Now we still have to, though, put the thumb up now for that slap test. So even though it's AC, now normally they'd say it hurts deep. So then we put the thumb up, and it doesn't hurt as much. And again, we're provocatively breaking him down. So that would be called a positive slap test. And that's, O'Brien described that in a published article, and he wanted to call it the O'Brien test. And I think it got called that, but maybe posthumously. Now, the other slap test, and there's a lot of them that we do, but one of my favorites is described by O'Driscoll. It's Valgus Shear. So, you know, in the elbow, Mike, you're talking on the elbow. So Mike will tell you about this moving valgus for the elbow for the ulnar collateral ligament, but it's similar up here, way up high. We jam the humeral head up against the superior labrum right there, and that hurts. So that's O'Driscoll's valgus shear. So those are the two I do for slaps. There are others. Or Andrews like to do the just rotation, clunking, trying to feel it in there for a slap. So that's for a slap test, and we talked about that internal impingement with the relocation test for pain. If the relocation for apprehension, you don't have to do anymore because they're already pregnant. So if you're pregnant, you're pregnant. So if you got apprehension, you got apprehension. So that's going through now. Stability testing in the shoulder in a lot of parts, stability is manifest by increased angulation, increased translation, apprehension in certain positions. So these are tests we do. So in the shoulder, we do, with the arm at the side, a sulcus sign where we pull down. Relax. So, and I put my fingers under. So he sits at about 7 or 8 millimeters, and he goes down about 4 or 5 millimeters. So he's down about 1 centimeter. So we grade them, but again, we won't get into the weeds about that. But that's a sulcus sign. And when we do that, we say, do you feel that? Oh. So if he did feel it, Yeah, I feel it go down. Then we say, is that your instability? And if he had multidirectional and he would say, yes, that's my instability, then we have a diagnosis. Then we also take and hold, rotate catwalk this way a little bit. So we also get him to relax and grab the humeral head, hand on top. Jeffrey Abrams just got load it in and then push backwards. He's really tight. And then forwards. So then we give that a distance measurement, and we ask him if he feels it, and we ask him if it reproduces his symptom complex. And qualitatively, it might be painful if we push it over a labral tear. Next, we do the apprehension sign. Remember, we did it laying down. That's the fulcrum. This is a crank test. So we put our finger on the front and our thumb on the back and bring up here. There's 3 apprehension signs. There's his, there's mine, and there's yours. So we're looking for his really, but if I'm apprehensive, I'm going to be really careful with this test. I'd probably put out a half a dozen shoulders in the office with this because I didn't quite have control of it. But so we keep it finger here, and if we feel it slide, we can quickly get it back in. If it slides too far, it's a dislocation. They're not going to be happy. So we're looking here for apprehension, a look on his face that he is fearful it's going to come out, or we might ask him the question, are you fearful it's going to come out? And if he says yes, then we call that apprehension. So that's the apprehension sign. Again, being careful about that so that it doesn't come out of joint. Dr. Neer, who was my mentor in New York, just died a month ago, a great shoulder teacher. He was on the fracture service, and the residents had this nice PhD lady that had shoulder instability, and they were trying to demonstrate the apprehension sign. He didn't like how they were doing it. So he got up, he knocked them out of the way, and he grabbed the lady's shoulder. He says, this is how you do it. And the lady's shoulder comes right out of joint. She's screaming and writhing in pain. He goes down, he sits back in the front row, and of course everybody's hilariously laughing in the audience. The residents are grabbing, trying to reduce this shoulder of this poor lady. So you have to be careful when you demonstrate tests in front of people. So that's sort of the instability manifestations we do in the shoulder. And apprehension is a very reliable sign for anterior instability. They could have additional instability. So we go through all that, and then we say, well, what have we done now? Special tests. We didn't look at the biceps for speeds. So with this, we put our hand here and flex a little bit, and then push up, and then we come down, looking for reproduction of pain here. And then there's Jurgensen's, which is resisted, not so good. The reason we're careful about this, because in our practice, we have ruptured 3 biceps tendons off of here with this test. So we asked him to hold it here, and an extension did that. One was a nice university professor. And so it goes crack, off it comes, and into the operating room we go because we got to fix it. So that's not a good thing to do. So a little protection there with that test. We haven't written that up, and we're going to write that up. It's called the Cristoforetti Mcgehee test, because they were the fellows that were in the room at the time when we did that. Maybe even one of them. So then that's a special test section. So what haven't we done? Well, we haven't done a vascular exam, like we would feel for his pulse on each side. We might do an Adson's maneuver where we ask and take an extension, he looks away, and he looks the same way. And we're looking for a diminution of the pulse. I think away is right, isn't it? Correct? Yeah. And then we do Wright's maneuver up here, about a number of people go normal up here. And the best one for thoracic outlet is sort of a Roos test where they put their arms up and open and close 15 times, looking for reproduction of symptoms, paresthesias down distally into the arms. So that's sort of, there are other ones that we may have skipped over. So we went through our sequencing pretty well, and so he only has a labral tear, superior labral tear, and so we'll inject his shoulder joint and put him on a rehab program and then do surgery in a couple weeks. I'm Baker.